Hi everybody, welcome to our module on hypercoagulable states. We say that patients have a hypercoagulable state when they have some predisposition to develop either venous or arterial thrombi. Now, many of the hypercoagulable states we'll discuss in this module lead to deep vein thromboses or pulmonary emboli. These are collectively called venous thromboembolism disorders. Some of the hypercoagulable states also lead to arterial thromboses, and these can present as stroke or myocardial infarction or an ischemic limb. Virchow's triad are the three elements that lead to formation of a thrombus, and Virchow's triad includes endothelial damage, stasis of blood, and hypercoagulability. A normal endothelium is very important for preventing thrombus formation. That's because the endothelium makes numerous natural anticoagulants. I've talked about a number of these in other modules, but these substances include nitric oxide, prostaglandins, also antithrombin, tissue plasminogen activator, and activated protein C. All of these prevent the formation of thrombus, and therefore if there is damage to the endothelium, you can get hypercoagulability and formation of a blood clot. Stasis of blood is the second element of Virchow's triad. Normal blood flow prevents the pooling of clotting factors. So if you have stasis of blood, there's increased risk of forming a thrombus. And then the third element is hypercoagulability, and this is the presence of any condition that increases the likelihood that a clot will form. So when you're in the hospital on rounds or even in the clinic, you'll hear people say that a patient has a hypercoagulable state. So let's talk about some of the common hypercoagulable states. And these are all clinical scenarios where one or more elements of Virchow's triad is present. So one of the most common hypercoagulable states is the post-op state after surgery. So patients are hypercoagulable in this condition because there is inflammation ongoing from healing from surgery, and this can lead to more formation of clots. In addition, they're often bedbound after surgery and immobile. This leads to stasis of blood. A lot of what keeps your blood moving is getting up and moving around. When you sit in one place for a long period of time, blood pools due to gravity in one place. In addition, there is endothelial damage following surgery, so this is a natural combination of the three elements of Virchow's triad, and this is why the post-op state is a common hypercoagulable state. Another common hypercoagulable state is trauma. For example, if a patient has had a fall or developed a hip fracture, they're hypercoagulable again from inflammation. Once again, they're usually immobile after a trauma, and that leads to stasis of blood, and there's endothelial damage from the trauma. Another common hypercoagulable state is a long plane flight. Patients are often advised to get up and walk around regularly on a long plane flight. The reason is if they sit for a long period of time, blood pools in their legs, and this can lead to deep vein thrombosis, and this is because the blood becomes static, or they develop stasis of the lower extremities from being immobile on the long plane flight. Malignancy is another very common hypercoagulable state. Any patient with a cancer is at increased risk for forming blood clots, and the development of deep vein thromboses or pulmonary emboli are a big problem on the oncology unit. There are a number of different reasons for this. I've listed some of them on this slide. Some tumors produce procoagulants like tissue factor. In addition, there are data suggesting that mucin, which is formed by many adenocarcinomas, is thrombogenic. In addition, normal cells may produce procoagulants as a reaction to the presence or growth of a tumor nearby. And then finally, patients with cancer often have decreased activity levels. They often need surgery. They often are on bed rest. And all of these things can conspire to lead to formation of a thrombus. Pregnancy is another well-described hypercoagulable state, and this probably evolved to protect women against excessive blood loss at delivery. Many clotting factors have their levels change when women are pregnant. For example, you can see increased fibrinogen. You can also see decreased protein S. And then the fetus also obstructs venous return, so this can lead to pooling and stasis of blood in the lower extremities. Many women who are pregnant develop lower extremity edema, and DVTs are common from the stasis of blood. A somewhat related situation is women who are taking oral contraceptive pills or OCPs. The estrogen in oral contraceptive pills increases the production of coagulation factor, and I talk about OCPs as a risk factor for thrombosis in some of the endocrine modules. Elevated homocysteine is another hypercoagulable state. Patients who have high homocysteine levels are at increased risk for thrombus. Homocysteine is an amino acid. This is its structure shown on the screen, and it's associated with both arterial and venous clots. High levels are believed to contribute to endothelial damage and also activation of some clotting factors. I talk about homocysteine in detail in the biochemistry modules, but I'll just review some highlights here. You can develop an elevated homocysteine level in the plasma if you are deficient in folate, B12, or vitamin B6. In addition, there's a rare condition called homocystinuria where children are born with a deficiency of the enzyme cystathionine beta synthase. They develop very high homocysteine levels, and a major cause of morbidity for these patients is the development of blood clots. Now, levels of homocysteine in the serum are lowered by folate. Unfortunately, most clinical trials where patients were given folate to lower their homocysteine levels showed no benefit in terms of reduction in myocardial infarction, stroke, or blood clot. But nevertheless, it's very important you know for step one that folate can lower the level of homocysteine in the plasma, and I talk about the reasons why this is the case in the biochemistry modules. The nephrotic syndrome is a well-described hypercoagulable state. There are multiple mechanisms. One of the main ones is loss of anti-clotting factors in the urine, especially antithrombin 3. You probably know that smoking is strongly associated with atherosclerosis and myocardial infarction or stroke. There are also some data linking smoking to increased rates of deep vein thrombosis or pulmonary embolism. The mechanism for this is not completely understood, but there is evidence that smoking increases fibrinogen levels. This may be a contributing factor. So everything I've talked about up to now are the common hypercoagulable states that you'll encounter on your clinical rotations. For the rest of this module, I'm going to talk about inherited thrombophilias. These are much more rare. These are inherited hypercoagulable states. They result in a genetic tendency to venous thromboembolism, meaning deep vein thrombosis or pulmonary emboli. Most involve defects in the coagulation pathways. We'll talk about all four of these hypercoagulable conditions I've listed on this slide now. The first one is the factor V Leiden mutation. It's named for Leiden in the Netherlands where it was first described. This is an abnormal factor V, as the name implies. Factor V among patients who have this mutation is not inactivated normally by activated protein C. For this reason, factor V remains active longer, and this leads to hypercoagulability. As a reminder, I've shown you at the bottom of the slide how protein C inactivates factor V. Protein C is activated by thrombomodulin to become activated protein C. It picks up protein S as a cofactor and then inactivates factor Va and factor VIIIa. In patients with the factor V Leiden mutation, the inactivation of factor V by activated protein C is inefficient. The factor V Leiden mutation is a point mutation in the factor V gene. A guanine base is changed to adenine. The result is a single amino acid substitution in the factor V molecule. Arginine is changed to glutamine. This occurs at position 506 in the factor V molecule. Our next disorder is the prothrombin gene mutation. It's technically called the prothrombin 20210 gene mutation. It results from a guanine to adenine base change in the prothrombin gene that occurs at nucleotide 20210, hence the name. If you are heterozygous, meaning you have one prothrombin gene with this gene mutation, there is a 30% rise in your prothrombin levels. For homozygous patients, it's even higher. What this means is that patients with this gene mutation make excess prothrombin, and this places them in a hypercoagulable state. Antithrombin 3 is a naturally occurring anticoagulant that inactivates a number of factors in the coagulation cascade. I talk about antithrombin 3 in more detail in the module on coagulation. If you are deficient in antithrombin 3 for any reason, you can have overactivity of the coagulation cascade, and this can lead to a hypercoagulable state. And you can be born with an inherited deficiency of antithrombin 3 due to a number of different gene mutations that have been described. In addition, there are several clinical scenarios where patients often develop an acquired deficiency of antithrombin 3. This includes liver disease. There can be underproduction of antithrombin 3 from the liver. In nephrotic syndrome, there are protein losses, as you may know, in the urine, and this includes antithrombin 3, and this can lead to a deficiency. And then finally, in disseminated intravascular coagulation, there's consumption of procoagulant and anticoagulant factors, including antithrombin 3, and that can lead to a deficiency. And you should know that an antithrombin 3 deficiency classically presents as heparin resistance. In another module, I talk about how the drug heparin works, but for our purposes here, you should know that it works by activating antithrombin 3. So if you are deficient in antithrombin 3, the patient can be exposed to escalating dosages of heparin, but there'll be little or no change in the PTT, and that's because there's not enough antithrombin 3 around for the heparin to work. If you are deficient in protein C or protein S, this will lead to a hypercoagulable state. As I mentioned a few slides ago, protein C is activated to become activated protein C. It combines with protein S as a cofactor, and together they inactivate factors Va and VIIIa. So if you are deficient in either protein C or protein S, you will be unable to normally inactivate these two clotting factors, and that leads to a hypercoagulable state. One of the most important things to know about a protein C deficiency is that it's associated with warfarin skin necrosis. When you initially administer the drug warfarin, this leads to a fall in the protein C level. Protein C is a vitamin K dependent factor. Its levels fall on warfarin therapy, and it has a very short half-life, so one of the first things that happens when patients take warfarin is that the protein C level falls. If you are already protein C deficient, this can lead to a very marked decrease in protein C. This can lead to a hypercoagulable state that results in thrombosis of the skin and presents as large, dark purple skin lesions. And I talk about warfarin in more detail in the pharmacology modules. The last hypercoagulable state I'm going to discuss is the antiphospholipid syndrome. This is a disorder caused by antiphospholipid antibodies, as the name implies. This disorder is very common among people who have lupus. It often occurs in association with lupus. However, it can also develop as a primary disease in patients who do not have lupus. The primary problem in the antiphospholipid syndrome is the presence of antibodies directed against phospholipids. What's confusing about this syndrome is that there are a number of different clinical consequences that result from those antibodies. So I recommend you think of the clinical consequences of the antibodies as falling into one of three categories. The first category is increased risk of venous and arterial thrombosis. This happens when people have antiphospholipids in their serum. Most commonly this presents as a deep vein thrombosis, although it also commonly presents as stroke from thrombosis in the central nervous system. Another hallmark of the antiphospholipid syndrome is recurrent fetal losses. The mechanism is believed to involve thrombosis of the placenta, although other factors are also important. But any woman who has several unexplained fetal losses often undergoes a workup for the antiphospholipid syndrome. That is a hallmark of the disorder. The second important clinical consequence of the antiphospholipid antibodies is an increased prothrombin time. We'll talk about that in a minute. And then finally, patients with these antibodies have a false positive result on syphilis screening tests. The RPR and the VDRL test will be positive even if these patients have never been exposed to syphilis, and that's because of the presence of the antiphospholipid antibodies. There are three antiphospholipid antibodies. The first one is called anticardiolipin. This is the antiphospholipid antibody that yields a false positive result on the syphilis screening tests RPR and VDRL. The reason for this is because syphilis also produces these antibodies, and that's what these tests detect. So if a patient has this antibody present as part of the antiphospholipid syndrome, they will test positive by these screening tests even if they've never been exposed to syphilis. The second antiphospholipid antibody is called the lupus anticoagulant. It gets this name because it interferes with the PTT test and therefore makes patients with lupus appear as if they are anticoagulated. Recall that the PTT test involves silica activating factor 12 and activating the intrinsic pathway of coagulation. The lupus anticoagulant interferes with this test and yields a false elevation. We'll talk more about that on the next slide. And then the last antiphospholipid antibody is called anti-beta-2 glycoprotein. If you suspect a patient of having the antiphospholipid syndrome, there are a number of tests you can do to detect the antibodies in the serum. For anticardiolipin and anti-beta-2 glycoprotein, you can do ELISA testing to directly identify the presence of these antibodies in the plasma. On the other hand, the lupus anticoagulant is usually identified indirectly by assessing the coagulation cascade. Like I told you before, this antibody interferes with coagulation testing, so assessment of the coagulation cascade is usually how the presence of the lupus anticoagulant is identified. So let's talk about how that works now. Here's a slide from our module on the coagulation cascade, and in that module I explained how the coagulation cascade requires phospholipids for certain steps. I talked about how factor 9A and 8A form a large multi-component complex on top of cell membranes. This complex requires phospholipids and it converts factor 10 into factor 10A. Now in the body, the phospholipids come from cell membranes. In the laboratory, when you're testing the intrinsic pathway, you need to add phospholipids in order to make the intrinsic pathway activate. And those phospholipids you add in the laboratory will be inactivated by the lupus anticoagulant, and that leads to a false prolongation of the PTT. To make this more clear, let's talk about how a PTT test is done in the laboratory. In the lab, you take a sample of a patient's serum, and to that sample you add contact factor, which will activate factor 12, as well as phospholipids and calcium. All three of these are required to make the coagulation cascade go. Once you add these three ingredients to the serum, blood clot will begin to form, and you measure the time it takes to form, and that time is the PTT. If the patient has a lupus anticoagulant floating around in their serum, that anticoagulant will bind to the phospholipid component of the test and interfere with the test, and that leads to a false prolongation of the PTT, and that's one way you detect the presence of a lupus anticoagulant in a patient who has the antiphospholipid syndrome. Once you identify a prolonged PTT in a patient in whom you suspect the presence of the lupus anticoagulant, you can confirm that the PTT is prolonged because of an inhibitor by doing a mixing study. Mixing studies are done to show the presence of any coagulation system inhibitor, including the lupus anticoagulant. To understand this, let's imagine that we have a sample of blood as shown here, which contains the inhibitor, the lupus anticoagulant. I've indicated the lupus anticoagulant by these little triangles, and the clotting factors are indicated by the blue circles. So in this sample, there is a prolonged PTT. That's because of the inhibitor. There are normal levels of the clotting factors. If you mix this sample with normal serum as part of a mixing study, you will get a mixture that still contains the inhibitor. This means that all the clotting factors, the ones that were present in the initial sample plus the ones from the normal serum, they will all be inhibited by the lupus anticoagulant, and the PTT will remain prolonged. That's the result you get from a mixing study in a patient who has the lupus anticoagulant. Contrast that with what you see from a mixing study when there's a clotting factor deficiency, for example, hemophilia. In these cases, the PTT will correct to normal. This occurs because you only need 50% of normal values for the clotting factors to get a normal PT or PTT. So consider a patient with hemophilia on the left side of the screen here. They have no clotting factors in their serum at all. They will obviously have a very long PTT. If you mix their serum with normal serum, you will now get a mixture that has 50% normal levels of factors like factor VIII, for example. This will lead to a normal PTT time. In other words, if the reason for the prolonged PTT is a clotting factor deficiency, then the PTT will correct from a mixing study. On the other hand, as we saw on the last slide, if the prolongation of the PTT is due to an inhibitor, it will not correct when you mix that patient's serum with normal serum. Now, as I told you before, the presence of the lupus anticoagulant is identified indirectly through testing of the clotting cascade. Unfortunately, only about 50% of patients with lupus anticoagulant have a prolonged PTT. So if you strongly suspect that they have a lupus anticoagulant, then sometimes other tests are used. These go by funny names like the dilute Russell Viper venom test, where venom from a snake is added to a blood sample to make the blood clot. Another one is called the Kaelin clotting time. These are both alternatives to the PTT test. They are substances that are added to make the blood clot, and the time to clot will be prolonged if the patient has a lupus anticoagulant present. And you can also confirm this with a mixing study. The time to clot will not correct with a mixing study. So here's a summary of the testing that can be done to detect the presence of antiphospholipid antibodies. It all begins with a blood sample. ELISA testing can be used to identify the anticardiolipin and anti-beta-2 glycoprotein antibodies. Then a clotting test and a mixing study is usually done to identify the presence of a lupus anticoagulant. A lot of patients have antiphospholipid antibodies but do not have the antiphospholipid syndrome. In order to have the syndrome, you need to have one laboratory plus one clinical criteria. So the lab criteria include presence of the lupus anticoagulant, which is identified through coagulation system testing, or presence of anticardiolipin or anti-beta-2 glycoprotein, which can both be identified by ELISA testing. You need to have two positive results more than 12 weeks apart, and that's because some patients develop transient levels of these antibodies that then quickly resolve. The clinical criteria include arterial or venous thromboses, fetal death after 10 weeks with a normal fetus, or more than 3 consecutive fetal losses before 10 weeks. And all of these are because fetal demise and fetal death are hallmarks of the antiphospholipid syndrome. So I'll finish this module by mentioning the hypercoagulable workup. This is a panel of tests that is sometimes done to identify underlying hypercoagulable states in patients who have thrombus disorders. You'll sometimes see this panel of tests ordered in patients who have an unprovoked deep vein thrombosis or pulmonary embolism. Unprovoked means it didn't occur after a long plane flight or after surgery. You may also see this panel of tests ordered in patients who have a stroke or myocardial infarction at an early age. You should be aware that this group of blood tests is controversial, it's expensive, and it rarely changes management. Many patients with one of these conditions need to be on blood thinners anyway, no matter what this set of tests reveals. In addition, if you do identify an underlying hypercoagulable abnormality, there are few data on how to manage that. And if you do decide to put the patient on indefinite anticoagulation because of a hypercoagulable state you find, there's a risk of bleeding associated with that. In addition, many of these patients are already on blood thinners, and the blood thinners interfere with many of the tests. So for all these reasons, it's a controversial panel of tests, but you will see it sometimes done. So now that we've gone through this module, you can understand all the tests that are part of the hypercoagulable workup. This includes measurement of an antithrombin level, measurement of protein C and S levels, tests for the factor V Leiden gene mutation and the prothrombin gene mutation, also tests for antiphospholipid antibodies, and sometimes age-appropriate cancer screening. And that concludes our module on hypercoagulable states.